A warm greetings to the students of second semester. Today's topic of lecture is Hamilton Depression Rating Scale. Before we go on to the scale, we have to understand what is depression. Depression, as you can see, there are many symptoms which are outlined here. Some of the very prominent ones are feeling of sadness, low mood, loss of interest in their usual activities, and also there would be a drastic change from a person's previous level of functioning, and that has those symptoms would have persisted for at least 2 weeks. And there could be changes in appetite, so the person can gain weight or lose weight, can sleep too much, too little, fatigue, low energy, feelings of worthlessness, helplessness, hopelessness, and inability to focus and concentrate that may interfere with daily tasks at home, work, school. Movements become really slow and agitated. There are thoughts about dying. There are suicidal ideations intact, and there are suicide attempts. These symptoms can cause the individual clinical significant distress in functioning in social, occupational, and personal domains of life. You have to rule out the possibilities of any other diagnosis. The symptoms can look similar to depression. Sorry, the symptoms can look similar to any other disorders than depression, but you have to be really mindful in doing a correct differential diagnosis. So, okay, so the symptoms must not be a result of substance abuse or any other medical condition. The doctors has to rule out mental health conditions that can have a depression component but are not strictly a major depressive disorder. For instance, it's not a bipolar disorder or it's not a schizoaffective disorder. In order for you to rule out such efficiently, it is very important that you take a detailed case history of the client with the informants present. Whoever brings the client to the clinic, you have to be very cautious in noting down the case history of the client. To be diagnosed with major depression, a person must not have had a manic or a hypomanic episode. The medical professional must determine the person's symptoms not by any other cause, such as medical condition, which could be a side effect of medication or related to the use of any other illicit substances. DSM had added some new features where you can give a diagnosis of major depressive disorder with mixed features. Here there could be presence of manic symptoms, but there are also depressant symptoms for the patients. However, they don't meet the full criteria for a hypomanic or a manic episode, that is bipolar disorder. Or it could be a depressive disorder with anxious distress. So there could be anxiety, tension, restlessness in addition to the symptoms of depression. So let us move on to the Hamilton Depression Rating Scale. It's also called as HAMD. HDRS is a multiple item questionnaire that is used to provide an indication of depression and as a guide to evaluate recovery. Max Hamilton published it first in 1960, which had undergone revisions in 1966, 67, 69, and 1980. This questionnaire is meant for diagnosing adults and it is used to rate the severity of their depression by probing into mood, feelings of guilt, suicidal ideation, insomnia, agitation, psychomotor retardation, anxiety, weight loss, and somatic symptoms. The original version contains 17 items, but four other questions not added to the total score were used to provide additional clinical information. So there are four more items in addition to the 17 items, and these four items they provide further clinical information about the client's depressive symptoms. Each item on this questionnaire is scored on a 3 or 5-point scale depending on the item, and the total score is compared to the corresponding descriptor. The assessment time in administering the scale is about 20 minutes. The patient is rated by the clinician on a 17 to 29 items on a 3-point or a 4-point Likert type scale. For 17-item version, a score of 0 to 7 is considered to be normal, but a score of 20 or higher is indicated to be at least of moderate severity. So that requires for entry into a clinical trial. That means you have to refer the person to trained professionals uh, to deal with the recovery process of the client. Questions 18 to 20 may be recorded to give further information about depression, whether diurnal variation or paranoid symptoms are present, but they are not part of the scale. And also, there is a Hamilton Depression Rating Interview Guide available, which I will be sharing with you in the class. So, it's a most widely clinician administered depression assessment scale. So, you would be rating the scale based on the interview that you carry out with the client. Okay. And depending on what the client says, correlating it with also the informant is saying, you're going to score the inventory. Scoring. So a score of 0 to 7 is generally accepted to be within normal range or within, while a score of 20 or higher is usually required for entry into clinical trial. And this scale was so efficient, reliable, and valid that it had been translated into many languages like French, German, Italian, Thai, Turkish. There is an interactive voice response version which is available. There is also a seasonal affective disorder version and a structured interview version. Okay, administering of the test. So, as a clinician, you have to be prepared with what kind of questions you want to ask the client in order to score the scale. So, this framing of questions will be helpful to you when you go through the structured interview guide laid down by Hamilton. I will be sharing it with you in the class. So then, before moving on to further parts of the test administration, you have to take down the demographic information of the client, and you have to give the instructions that I would be rating you on this scale. So I would be asking you some questions, and they're all meant for the purposes of treatment. So when we come to scoring, the scores between 0 to 7 suggest that the person is not depressed. A score between 8 to 13 can mean very mild scores, mild depression. Score between 14 to 18 means moderate depression. 19 to 22 means severe depression. And greater than 23 is considered to be a very severe form of depression requiring immediate emergency admission for treatment. A table should be constructed with two columns mentioned where you have the raw scores and you have the interpretation. In interpretation, you start off with the client's demographic information, what HDRS is, what it measures, and then you triangulate the data based on the scores obtained by the client on the scale, the case history data, as well as your observations of the client throughout the case history taking sessions. And then you end with your recommendations for his treatment and prognosis. And conclusion, you write a short description of the scores obtained by the client and the interpretation of the level of depression the client has. A criticism of HDRS is it places more emphasis on insomnia than on feelings of hopelessness or, the self-destructive thoughts, suicidal cognitions and actions. So you can see that it places a much more emphasis on the biological dysfunctionality of the client than on the cognitive dysfunctionality of the client. So, an antidepressant may show statistical efficacy even though thoughts of suicide increase but sleep is improved. Antidepressant as a side effect increases sexual gastrointestinal symptom ratings and can register as being less effective in treating the depression itself than it actually is. So, in previously, when I have mentioned that it is used for diagnosis but also in keeping track of the recovery progress of the client, which means that you would be using the scale over the treatment phase of the client. So you would be using it again and again. So, but many of the antidepressants that would be prescribed to the client, it would have side effects. It could cause sexual dysfunctions. It could cause gastrointestinal symptoms, amongst many, and that itself can bring up the scores in HTRS, which is a criticism of the HTRS. So you have to be mindful as a clinician when you are diagnosing it again on the client. So this is all for today's lecture. I hope it was a fruitful discussion. I hope to see you all again in the next class. Thank you. Have a good day ahead.